very happy to have Dr. Judith Mwanza. Judith, or Judy, is a medical doctor with a master's degree in epidemiology and a PhD in public health. She has more than 10 years experience in public health. She's worked in clinical, programmatic, and research levels, has experience both in government and non-government sectors. And now, as of about a year ago, I think, Judith is working as a senior epidemiologist at the National Cancer Registry for South Africa. She leads the Cancer Data Analytics Technical Working Group of the U.S.-South Africa Cancer Alliance and works closely with cancer organizations such as CANSA, CHOC, and Living with Cancer. Judith has previously worked in TB, HIV, and other infectious diseases, hence her interest in infection-related cancers. She is co-PI of the CARTA Research Hub that we have within IDORI now that has the acronym DISCOURSE. She will be looking at research on cervical cancer and HIV, among other projects. Judith holds an honorary researcher position at Wits University and also at UCT. So I want to thank you for facilitating and look forward to the session.
Thank you. Thank you, Rob. So the first speaker that I'll call up is Dr. Masvita Mchengeti. She's the head of department at the National Cancer Registry at the NHLS, the National Health Laboratory Services, and she leads the IAC GICR. So that's the Global Initiative on Cancer Registries Development and the International Agency for Research in Cancer Collaboration. So we have a center of expertise at the National Cancer Registry for that, and she heads that, and it's within the African Cancer Registry Network. Her work focuses on cancer surveillance, cancer epidemiological research, capacity building, and cancer policy development in African populations. She leads the South African HIV Cancer Match Study. This is a national cohort of people living with HIV, and it explores cancer patterns in this population in South Africa. She supports the training of cancer epidemiologists through supervision of master's and PhD students and supporting the South African Field Epidemiology Training Program. She's a senior lecturer at the Wits School of Public Health and a research associate at the South African Center for Epidemiological Modeling Analysis at the Stellenbosch University. Please let's welcome Dr. Mchengeti.
Hello everyone. I hope you can hear me clearly now. Yes. I just want to just give an overview of our journey as the National Cancer Registry in cancer surveillance in South Africa. The National Cancer Registry is actually part of the National Institute of Communicable Diseases, yes, the NICD. We are a center within NICD, and I'm just going to give you, firstly, the legal framework that establishes the Cancer Registry as the cancer surveillance arm of the state, and talk a bit about leadership, succession planning, and human resources over the years and how they have impacted cancer surveillance in South Africa, where our funding comes from, the functions of the registry, and the future of cancer surveillance in South Africa. The National Cancer Registry is established through the Regulation 380 of the National Health Act, and this is a law that makes cancer reportable in South Africa. So it is compulsory to report cancers to the National Cancer Registry. And this same law defines the functions or the objectives of the National Cancer Registry. And these functions include cancer surveillance, and this wording has been lifted from the regulation itself, which is collection, validation, managing, analyzing, and reporting of all data relating to cancer. And The law also requires us to establish population-based cancer registration. There are different types of cancer registration, like pathology-based cancer registration, hospital-based cancer registration, and population-based cancer registration is when you collect all cancers within a population. That means those who are confirmed by pathology and those who are diagnosed by other means such as radiology, and also including those that are only found on the death certificate. So this is a way of estimating the true burden of cancer in any population. Regulation 380 also requires us to provide information to the state and to the public, and this information on cancer is for education and training, awareness and research, as well as to inform prioritization of cancers and interventions. Many of you will know that there was a time where the Cancer Registry was over 10 years behind in reporting cancer incidents in the country. And the reason I started with the legislation was that reporting sources did not have any legal coverage. So the Cancer Registry, although it started in 1986, this was a voluntary registry, and the reporting sources were reporting data at their own risk. So when the legislation came into place, we were able to see that cancer reporting improved, and particularly for private sector, they had withheld a significant amount of cancer data and were not able to estimate the true burden of cancer in the country. In 1991, that's when the National Cancer Registry had its first substantive head, who was Professor Freddie Sitas. And at this time, between 1991 and 2002, timely reports were available and people were able to know what is going on. But unfortunately, after he immigrated, the post of head of department was not filled until November 2010, when the late Dr. Danuta Kiokoski became head. So during this time, people who were retiring, people who passed away, people who resigned, their posts were not replaced, and the budget of the National Cancer Registry was progressively shrinking, and there was no confidence in people sending data to the Cancer Registry because they knew there was no head, there was no accountability, and these were really dark years in terms of cancer surveillance in South Africa. Dr. Danuta Kiokoski was also my PhD supervisor, and this speaks to succession planning, that we began to build capacity in terms of cancer epidemiology, and during the time that she was head, there was no post of epidemiologist. There were coders, and there were a few medical scientists, but there were no, that post did actually not exist. From 2016, the late Dr. Elvira Singh took over from the National Cancer Registry up to 2022 at the time of her passing. At this time, what was happening was that she had to fill in a lot of gaps in terms of human resources because the staffing was very, very little. So this staffing was being filled by temporary contracts from a lot of different funding sources, like pharmaceutical companies, just to plug that human resources crisis, and then to motivate for posts to be reinstated, which take a bit of, like, almost 2 years, that process within the government system at that time. And this was the time where we actually did a lot of the catch-up in terms of the backlog, and she was awarded the Cancer Otler Memorial Award in 2022 posthumously. Then who funds cancer surveillance in South Africa? Who is actually paying for this? So about a third of the funding comes from the National Department of Health through a grant that is dedicated to the National Cancer Registry. It's only a third because of the problems that I've said before, that a lot of posts were lost, and and if you don't fill a post within government, you lose it, and the budget progressively shrinks. So, but the NICD funds at least a third of the funding of the National Cancer Registry at this time, and the South African Medical Research Council funded quite a lot of research within the Cancer Registry, and a lot of the researchers were doing some surveillance work, and they also funded the Ekurhuleni population-based cancer registry when it was initiated. They also fund the Eastern Cape Cancer Registry within, they also fund the Eastern Cape population-based cancer registry, which is a rural cancer registry in the Eastern Cape. As I said, we had some pharmaceutical companies just give us some once-off grants to, as stopgap measures throughout the time, like Janssen and Takeda. And the KwaZulu-Natal population-based cancer registry is funded through Bristol Myers Squibb Foundation. We also rely a lot on academic grants, where we turn a surveillance mandate into a research question so that we can get research to fund our core mandate of surveillance. What are the functions of the registry? Our pathology-based cancer registry, which was started in 1986, only records cancers that are confirmed pathologically. But this is not enough, because it misses a lot of these cancers that are not well biopsied. If you look at cancers like lung cancer or pancreatic cancer, they don't always have a pathological confirmation. For the most part, radiology takes a big part, and sometimes tumor markers. So such cancers are grossly underestimated within the pathology registry, and they do not meet the standard, the minimum standard required by the International Agency for Research in Cancer. So that is why the need for Regulation 380 to stipulate that population-based surveillance is required. So we have population-based cancer registries in Ekurhuleni and in KwaZulu-Natal. This population-based mandate is an unfunded mandate. So at present, the government only funds one epidemiologist and 2 surveillance officers out of all the population-based registries. We also have a childhood cancer registry. The childhood cancer is a national priority for South Africa and also for the World Health Organization. That's why a standalone childhood cancer registry is required. We also supervise masters and PhD students through our research and training program. We do surveillance of cancer in people living with HIV. You'll hear a little bit more about that through the South African HIV Cancer Match study. We are in the first steps of establishing an inherited cancer surveillance database using the NHLS CDW, and we monitor the cervical cancer elimination strategy. You also hear more about that from Sizeka. Which cancers are our top cancers? In women, it's breast, cervical cancer, uterus, and non-Hodgkin's lymphoma. In men, it's prostate, colorectal. I'm not sure what has happened to this slide. It's not showing everything. What is the future of cancer registry in South Africa? We would like to have interactive cancer dashboards. Those of you who have used the GlobalCan website, you know that you can be able to click, and then come up with bar graphs, pie charts, etc., Excel spreadsheets from the cancer registry. But we want one specific for South Africa that will have the granularity of the provinces, our population groups, and HIV status. We've also added a cancer module to the Notifiable Medical Conditions app. So, South Africa has very strong infectious disease surveillance systems, so we want to leverage on those so that clinicians can be able to use their cell phone, tablet, or computer to input cancer registry information using our official form that is now on the Notifiable Medical Conditions app. So we are testing this, and we'll be rolling it out soon. We'll also be including cancer patients in cancer surveillance. We would like to meaningfully include cancer patients by working with an NGO called Living with Cancer, which is a patient-led registry where cancer patients can be able to input, register their own cancers and attach any proof of, and then we can then merge this with the rest of the data. This is, we even have a joint media campaign with the National Cancer Registry, Cancer Association of South Africa, Living with Cancer, and a marketing and PR company that is called Ogilvy. I think I did mention that we have formed a group called the South African National Cancer Prevention Services with the express intent of doing surveillance of inherited cancers or familial cancers in the country. The National Public Health Institute of South Africa will have cancer surveillance as a separate institute from infectious diseases and along with other surveillance of other diseases. So this is, again, still in the pipeline. And in summary, legislation, leadership, and human resources and funding are critical for sustainability of cancer surveillance. And we are leveraging on the strong infectious disease surveillance systems that exist in South Africa to improve cancer surveillance. And we are also wanting to meaningfully include cancer patients in cancer surveillance so that we can fill the gaps in cancer surveillance. And we look towards using cancer surveillance as a prevention tool in inherited cancers. I would like to acknowledge the National Cancer Registry team, the NICD and NHLS, Cancer, Living with Cancer, and Ogilvy, the SunCaps team, as well as our funders. Thank you very much for your attention.
So up next is Carol Metuke. She's a data scientist and epidemiologist at the National Cancer Registry here in South Africa. She holds an MSc in epidemiology, public health informatics from the University of the Witwatersrand and a master's in public health from Manchester Metropolitan University in the UK. Her research focuses on the epidemiology of comorbidities, automation of data management processes, and data visualization. Carol is involved in linking nationwide cancer and HIV data to create the South African HIV match study that Dr. Mchengeti spoke about. She is currently pursuing her PhD at the University of Bern in Switzerland, and she focuses on trends in the epidemiology of non-Hodgkin's lymphomas in South Africa in relation to the evolving HIV epidemic. So her project actually aims to describe the trends in incidence and mortality of non-Hodgkin's lymphoma and its subtypes in the context of the HIV epidemic, as well as the era of the antiretroviral rollout in South Africa. Let's welcome Carol. Thank you.
Okay, we've heard Dr. Mchengeti talking about the different data sources that we use at NCR to be able to fulfill our mandate. So in this presentation, I will take you through how we harmonize this data to be able to report on the different cancers and the risk factors in South Africa. So our main data source, the Cancer Registry, is data from the National Health Laboratory Service, which is the lab services in all the public health facilities in South Africa. And we also get data from the private laboratories. We have all the big laboratories, but as time passes and more laboratories come up, we'll link with these people to get all their cancer diagnosis into our system. So there has been a pipeline that has already been set up at the registry to receive data from these laboratories. In addition to that, we also partner with managed care programs such as ICON Oncology and SIOC, where these are a group of specialists that screen the patient before the medical aid can go ahead to treat them for their cancer and everything. So they have a database with all the information of the patients that were diagnosed with cancer. So we get that information to complement our various data sources as well. In addition to that, Dr. Mchengeti spoke about the patient-led registry, which is Living with Cancer. We have already set up the website to enable them to capture the data, their information into our system, and later on it will all be compiled together. We've not yet integrated this into our analysis, as this is an initiative that has just started. And we also have the NMC app that is also being set up to get information from the different medical doctors, because with cancer, having a pathology-based registry only, it limits the reporting of cancers that are not easily diagnosed pathologically but are diagnosed clinically. So all these data sources now has to come together into a harmonized database where we take care of duplicates. We remove the duplicates from the various sources to be able to report on the incidence of cancer in South Africa and the risk factors of the different cancers as well. In addition to that, we use this information to complement the information that already exists in the population-based registry and the childhood cancer registries as well. So now the question is, how do we do that? We use two main techniques at the registry to harmonize our databases and ensure completeness. The first technique is text mining. So basically, before we started using text mining, from the National Health Laboratory Services, we were selecting cancer report based on the SNOMED code. But over time, when they get updated and everything, it does not necessarily get updated in the system. So that might make us miss some of the cancer cases. So what we did was to actually request for all the free text report from the lab, from the public labs. So all the histology and cytology report comes to us. And then we take this report and take the reports that were already classified as cancers. We train some algorithms, and then we use this algorithm to classify this free text into malignant or non-malignant. And based on that, we can now pull the malignant report and send it to the coders for coding, instead of sending the whole histology or cytology that we receive from the public labs. So if you want to know more about that, you can look at our paper on the identification of malignancy from free text histopathology report. So the second technique is called the record linkage technique, because we are receiving data from different sources, and these people can find themselves across all the sources. We need to make sure that we don't report them as duplicate, and we need to make sure that the information for each patient is complete as well. So in record linkage, we basically try to identify all the records belonging to the same person within all these databases. So the first step is to identify the linkage variables. These are generally your first name, your surname, your date of birth, the ID, depending on the level of completeness, and your sex or gender. So after doing that, we have to clean and standardize those variables, because it's coming from various sources and people type in different ways. We need to make sure if it's the name, we take out all the special characters in the name. We have them all lower cases. We need to make sure the variable names are the same across all databases. So after that, we then have to do a deterministic linkage. A deterministic linkage is basically identifying the patient across all the database. If they have an exact match on all the linkage variables or on the ID number, then we consider that this is the same person. After doing that, we then proceed with the probabilistic linkage. Because routine data and data capturing is prone to errors, to typing errors. There might be, somebody might type the name may be Carol with an E, Carol without an E, and every other information is the same. So we then use algorithm that help us calculate the probability that record A is the same as record B in the other data set. And based on that, we can say this is probably the same person because it has a high probability score, it has a high matching score. So in addition to our reporting mandate in terms of incidents, we also use these techniques for population and cancer-specific surveillance in South Africa. So for instance, the South African HIV cancer match study, where we get reports from the public laboratories, HIV records from the public laboratories. We identify all the HIV positive records, and we create an HIV cohort. And in this HIV cohort, we then link it to our cancers that we have in the at the registry. And once we have done this linkage, we are able to identify those who have HIV and who have been diagnosed with specific cancers. And then we can then monitor this, we can monitor the incidence and the risk factor of cancers among people living with HIV. As of now, our cohort have about 5 million people living with HIV from 2004 to 2014. And we are currently updating it to include 2015 up to 2021. If you want to know more about the techniques used for the SAM study, you can look at this paper. And these are some of our outputs from the SAM study, looking at the cancer diagnosis and describing some of the differences between cancer among people living with HIV and the general population. So in addition to that, we also use the data to monitor the cervical cancer screening, In addition to that, we use it to monitor the WHO elimination cancer goals, where it normally requires that 90% of girls within the age of 15 should be vaccinated with the HPV vaccine. 70% of age of screening should be screened, and 90% who have been diagnosed with a precancerous lesion or cancer should be on treatment. So we link the screening data to the HIV data, to the cancer data, and to the vital status data to try to monitor this goal that was set up by the WHO. As of now, we are not yet adding the HPV vaccination data, but that is something that we will be adding over time. So in summary, the National Cancer Registry uses different sources to meet its mandate of providing comprehensive cancer information to state organs and the public in general. Data harmonization is key to ensure completeness and ensure surveillance across specific population group and to monitor the progress towards set goals. We use techniques like text mining and record linkage in order to harmonize our data efficiently. So I would like to acknowledge the National Health Laboratory Service, IDORI Southern Africa, University of Bern, Swiss TPH, and all our data sources. Thank you.
So the last speaker, last but not least, is Sizeka Mashele. He's a cancer epidemiologist, also at the National Cancer Registry here in South Africa. He holds a master's degree, Master of Science in Field Epidemiology from Wits University and an MSc in Medical Sciences from the University of Pretoria. He is currently pursuing a PhD in epidemiology at the University of Basel in Switzerland, and he's focusing on evaluating cervical cancer screening programs in South Africa. Sizeka is the program coordinator for the Center of Expertise, the one that we said that Dr. Mchengeti heads. So he's the program coordinator for that, and he coordinates training programs for integrating cervical cancer screening and cervical cancer registry data in sub-Saharan Africa. In terms of where he's worked previously, he's worked as a surveillance manager at the Kuruleni Population-Based Cancer Registry. He's also worked as a microbiologist and a research technician in various pharmaceutical and research institutions. Let's welcome Sizeka.
Thank you so much, Chair, for a wonderful introduction. So this morning, I won't spend too much of your time, but I will actually give you the most important information for sub-Saharan Africa. I will be talking about the elimination mandate, the Center of Expertise or Collaborating Center, the mandate and how it was established or when. I will also touch a little bit about the activities that we have done, as well as the research studies that we have done. So maybe let me start by telling you that the cervical cancer we are talking about today here in South Africa is the second most common cancer diagnosed. And it has the incidence rate, standardized incidence rate, it's at 23 per 100,000 per annum. And there is 1 in 41 women who will develop cervical cancer in their lifetime. So that is the lifetime risk. So back to Collaborating Center or Center of Expertise, I will use the two words interchangeably and I will tell you why later. So in 2020, the World Health Organization, they've put up a strategy to eliminate cervical cancer as a public health problem, because this cancer is almost 100% preventable. And if we can prevent it, we can eliminate it. So they identified pillars that they should be targeted. There are 3 pillars, which the first one, which is prevention through vaccines, screening and treatment of precancerous lesion, as well as timely treatment of invasive cervical cancer. So the strategy, we call it the 90-70-90 cervical cancer elimination strategy. What does it mean? It means that the first 90, it means that if all countries by 2030, they can vaccinate at least 90% of girls with HPV vaccines. If by 2030 they can vaccinate 90, we will be on the right path to eliminating cervical cancer. The second pillar, which talks to screening, it says that at least if we can screen 70% of women at the age of 35 and 45 with high performance tests. And the last 90, it tells us that so when you screen, you will identify precancers. So from those precancers, if you can at least treat 90% of women with precancers who have precancers, if you can treat them, and also if we can treat 90% of women who have invasive cancer or manage them, we will be in the right path to elimination. And the goal is for the world to have at least the ASR of less than 4 per 100,000 per annum. So after the strategy has been put in place, the International Agency for Research on Cancer, they have done some groundwork to look at the feasibility of this in our settings. So these are some of the things that they have found, especially for sub-Saharan Africa. Our data systems here in sub-Saharan Africa, they are weak and they are fragmented. Our data quality is poor, and we have a lot of silos. I can give you an example of from this pictorial that you see here. This is the situation that we have here in South Africa. We have the HPV vaccination. The HPV vaccination, it's with the National Department of Basic Education through the school health program. That's where the data for these vaccinations are sitting. We have the screening data. Screening data is sitting at the National Health Laboratory Services. We have treatment, which is sitting at the hospitals and some at the doctors' offices. We also have the population-based cancer registries, which is with us, the National Cancer Registry, and we also have the death registry. So you can see all the silos. We need all these data to be able to monitor, but you see it's in silos. So for that reason, the International Agency for Research on Cancer, through the Global Initiative or Cancer Registry Development, they have started to put up collaborating centers that we call them now Center of Expertise. So if you look on this slide, you can see all the blue stars here. There are a lot of blue stars all over the world. These are the collaborating centers or Center of Expertise on cancer. But here in sub-Saharan Africa, before the enaction of the strategy, we never had a single collaborating center. So that's why they came up to say, okay, cervical cancer is a big problem in sub-Saharan Africa, but we don't even have the collaborating center, and we realized that data systems are weak and so forth. So they came up with the collaborating centers. They established collaborating centers. They've put one in Cote d'Ivoire, in Abidjan, one in Nairobi, and one in South Africa, which is within the National Cancer Registry. So the one in Abidjan is responsible for training and data quality for the Francophone speaking countries. And the Nairobi, they are responsible for data quality for the whole English-speaking region. And us, we are responsible for the English-speaking region in terms of record linkage trainings. So we inaugurated in 2022. This event was here in South Africa at the NHLS or NICD, and we had a lot of stakeholders, including the National Department of Health, the World Health Organization, civil society, research, as well as academia. So within the Center of Expertise, we are led by Dr. Muchengeti, who is the HOD, Head of Department for the National Cancer Registry. And we also have Dr. Judith Mwansa, whom we report directly to. So the collaborating center is coordinated by myself here. I'm responsible for cervical cancer monitoring and elimination. And Natasha Abraham, who's responsible for childhood cancer registration. Because we are the Center of Expertise, it's not only us. We have the data science team that is led by Carol Mitekoa. She's working together with Matsidiso as well as Tinashe. So what do we do? What's our role? So we are mandated to provide training programs for healthcare professionals, cancer registrars, and other relevant stakeholders to improve knowledge and skills related to cervical and childhood cancer in sub-Saharan Africa. But for the cervical cancer wing, we specifically provide a specific training on record linkage of cervical cancer screening records and registry database for the purpose of cancer control as well as research. So the record linkage is what Carol spoke about, that we link record from various data sources. Like I've mentioned earlier that we have data silos. So those data silos we need to integrate all those, harmonize that data together. So we provide a specific training on that. We also have responsibility for childhood cancer registration that I will not talk about today. So this is the modules that we offer. We usually have online as well as in-person trainings. So we cover various courses during that training. But for record linkage specifically, Dr. Mazwita always gives this course, and we will teach people how to harmonize these data sources using Stata. We teach in Stata, we'll introduce them to Stata, we'll teach them how to clean data in Stata, as well as finally doing the record linkage. And we use Stata specifically for that training. However, we are the Center of Expertise. We have experts who are doing this work in R as well as in Python. So as if we have got big data like 5 million, 111 million with SAM, Stata cannot cope with that, so they use Python, sometimes they use R. So as we give this training, we also advise that if they have large data or they want to be skilled in R or Python, we also do that. So we partner with our international collaborators. We have Professor Sasieni from Queen Mary University. You know, in Europe, they've been monitoring these programs, and cervical cancer is not that of a big problem. So we also learn from them. So Prof. Sasieni always teach during our trainings about the monitoring, how can we monitor these programs. We also invite other speakers like Dr. Joffe, who's the director for Strengthening Oncology Research Unit. She's based here at University of Witwatersrand. So she will, because when we train people from different countries, so she will actually teach us of the importance of doing multi-sectoral as well as multi-country research. What is the benefit of that? While Dr. Makua, she is the former Chief Director for Women's Health from the National Department of Health. She will also teach or capacitate our trainees in terms of how can we engage stakeholders when we want to eliminate cervical cancer, because as we have seen that this data is in different sources, obviously you need to have some skill to engage all stakeholders. So we've been inaugurated in 2022. Since 2022, we have trained over 200 people or participants from over 25 countries, and we train them virtually as well as in person. However, we only trained 25 participants in person, and you can see that we trained about 52%. There's more of balance between, gender balance, though it cannot be 50-50 exact. So this is what we have done so far. And maybe let me talk about the training that we had last week. Just last week, we concluded our in-person training for record linkage. It was from 12 to 16. We had participants from Rwanda, Namibia, Mauritius, Eswatini, Tanzania, Zambia, as well as participants from here in South Africa. So the people that we trained, they come to South Africa with their own different databases. So what we do here is to help them to link these databases. So let me also talk about some outcomes of that training that we had. So because these people had their own data that they brought, and we helped them to link, and they linked successfully. And for this training, we were fortunate to have this training at the time where our Center of Expertise or Collaborating Center was given a slot at the Eurogen Conference, which is the International Multidisciplinary HPV Congress that will take place next year, 16 to 19 March in Porto. So the Collaborating Center has been given a slot to have a session in that. So we used that training that we had to actually link data and come up with topics that can be presented. So Eswatini will be presenting cervical cancer screening in women with and without HIV, while Mauritius and Rwanda, they will be doing cervical cancer survival. We also have Zimbabwe and Tanzania that will be doing cervical cancer screening outcomes by HIV in Bulawayo and Kilimanjaro, respectively. So we will also do research for South Africa, because what I've just presented is for the other countries. There was nothing for South Africa. At Eurogen, those presentations are for other countries in Sub-Saharan Africa. So we also have research here at home using the data that Carol just presented for SACS. So the goal of this study, we call it the SACS cohort. So it's a South African cervical cancer screening cohort. It's a cohort of women who are eligible for screening, who are undergoing screening in our public sector here in South Africa. And we use this study to actually inform cervical cancer control in women living in South Africa. So through the record linkage techniques, we are harmonizing all these data sources and we put them together. This study will actually help us to evaluate our screening programs, to check if our screening are effective. For example, you will have someone who will screen, and our guidelines will say that you need to come for screening every 10 years if you are HIV negative. Let me put it, low risk or HIV negative, you come every 10 years. So you find that someone will go for screening now at age 30, but at age 36, that particular woman develops cervical cancer. So it means there's something wrong there. Why do we develop cancer before our next screening is due? So this study will help us to do that. And we do this study in collaboration with Swiss TPH, Dr. Julia Bullier, and Dr. Eric Engels from the Center for Division of Cancer Epidemiology and Genetics from the NCI. So we not only do research studies, we also do stakeholder engagement, and we also work hand in hand with the National Department of Health here at home. So since 2023, we inaugurated at 2022, 2023, we started working closely with the National Department of Health. So South Africa is currently adopting the WHO elimination strategy. So through this series of stakeholder engagement where all stakeholders, research, academia, private sector, who are working on cervical cancer, we come together to write or adopt the WHO elimination strategy. So currently, the National Department of Health, they've got a mature draft of the strategy for South Africa. It's called the Strategic Framework for Elimination of Cervical Cancer in South Africa. You can see this is dated 2024. So it's an ongoing work. So we not only support South Africa, we also support other countries. Before the end of this financial year, we will be able to support Rwanda as they are about to have their own stakeholder engagements there so that they can adopt the strategy, the elimination strategy, because their strategy is generic. It's not one size fits all. So each country has to make sure that whatever is there, what is feasible for them. Yeah, so in future, as I'm about to finish, we want to continue strengthening data-driven monitoring of cervical cancer elimination by giving training for the African Cancer Registry Network members. We will also continue doing the stakeholder engagement, and we will also continue teaching this probabilistic record linkage. Probabilistic record linkage because you know that in our settings, you are not required to bring an ID when you go to the hospital. So obviously you will go to different hospitals and you will be registered as a new patient. So we use the probabilistic methods to harmonize all that data. This is what Carol just presented. And we want to continue doing capacity building in cancer research, because most of the people that we train, we know that they are based in the registries. They are not researchers. They are not equipped in terms of data analysis, scientific writing, and scientific communication. So we want to continue doing that in our setting. And I want to acknowledge all these stakeholders here, some of funders like NCI, Center for Global Health, as well as Vital Strategies. And thank you so much.
Thank you, Sizeka. Thank you so much. Can we have a round of applause for all the three speakers? Okay, so I'll now open up the session for questions. So we've heard from the first speaker introducing what the National Cancer Registry does, and then from the second speaker also showing us how we go about with the data, and the last speaker also showcasing how we assist in the region as well as conduct research in our registry, and also overall the fact that we are able to leverage, to work on the research studies to also enhance our surveillance. So I'll open up for questions. Maybe if I can have the first round of 5, and if you can direct maybe we'll just hear the question, I can direct it to the respective speaker, or if you have the name of the respective speaker, you can. Thank you.
Can I go first? Good evening, ladies and gentlemen. Mine is actually a comment to Sizek. I know State and R can handle data sets quite robustly, but then in terms of linking databases, I would strongly recommend SQL. It comes in very comfortably and handy, especially when you want to generate a data set that is desired for analysis from multiple databases. So it's just a comment from me. And then the question that I have is that we have the 90-70-90 strategy, but then obviously we are going to, as we combine all this data set or link the data sets or databases and generate information from there, we're going to have insights. And then are there immediate actions that are going to be taken based on the insights that we will get from analyzing these databases apart from the 90-70-90 initiative that is already adopted?
Thank you. Next question. There's one. There.
Judy, should I?
Oh, sorry, I didn't.
It's okay. It's okay. You can go with the other person, then I'll follow.
Is yours a question?
Mine is a question. Mine is, I don't know if this is working. There it is. Could I ask that each person introduce themselves and say where they're from? So I'm Rob Bryman. I'm from the Infectious Diseases and Oncology Research Institute. And I think my question is for Masvita, although I think each of the speakers could respond, and thank you for the presentations. You know, I think a lot of people don't have a clear idea of how critical the data could be to assess programs. And I wonder if you could comment a bit on, you know, as IDORI works on improving access to screening for cancer and improves access to diagnostics, that could dramatically impact the mortality from cancer, because presumably people would get identified earlier and get onto therapy earlier. And I wonder if you could comment on the quality of the data, or what sort of data could be used to assess how such a program for screening improves outcomes. The other thing too, Masvita, I think it would be nice to have a sense of is, can the National Cancer Registry give us an idea on trends of cancer? Are we seeing certain cancers increasing in certain physical or geographic areas that could help to focus research?
Thank you, Rob. Him, and then you can.
Okay, hi everyone. I'm Ruth. I'm from the School of Public Health, Priceless, South Africa. So I'm just interested to know what you're doing about the underreporting of cancer, particularly breast cancer. You know, there are times that I have come across a report that suggested from WHO that the figures that were reported by them were higher compared to what the registry reported. So what are you doing about that? So my question goes to the first two presenters. Thank you.
Thank you. I think we have one more on this side.
Hi, good afternoon or morning, everyone. I'm Sulaiman Hassan. I'm also from IDORI. I have two questions, can be directed at any one of the speakers. The first one is, what are you doing in terms of active surveillance? So to pick up on what the other two questions were, from one of those charts that was shown, it was shown that the top causes of cancer in South Africa, and I didn't even see lung cancer there. And I say to myself, but that's definitely a huge mistake, because these cancers aren't diagnosed, not because there were no biopsies done or patients didn't present, but these patients are in the community, they have the disease and they are never picked up. So what are we doing to identify those cases? Because there's a gross underrepresentation of that. That's one. The second question that I have is, the registry is an excellent idea, but who has access to this data? And who from third parties, like for example, researchers from IDORI themselves, can they access that data and publish it to inform policy making? Or is that data just available to people at the NHLS? Thanks.
Okay, thank you. I think I'll just let the presenters respond to those comments, and then we can take another round if need be.
Okay, can you hear me? Yes. I think I will start with the question on software. So the linkage training that we're doing it in cancer registrars. They're not actually trained in epidemiology. So the software that we choose to teach in is the one that is readily available, and because we get funding for an unlimited starter license for all the people in sub-Saharan Africa, and also it's not too technical for them, and something that they have, and they're very small data sets. They're very small data sets, so that is the other reason we use. But for our big linkage studies, I think Carol will may be able to give more detail. We use Python, and we also have machine learning and in Python, and we also have G-Link, which uses SQL from Statistics Canada. But that is because South Africa is linking like 120 million records of people with HIV to 2 million records of people with cancer, and 14 million with screened. So we have massive databases, so we have to then tailor it for that. But for training basic things, we don't want to discourage the people from the region from linkage just because we are using things that they are not familiar with. In terms of the insights that we get from the data, I think Sizeka alluded to it a little bit about interval cancers. Our interval's correct. Right now we are saying women with HIV every 3 years we screen if they have no abnormality, or yearly if they have an abnormality, and 10 years for women without HIV. Is that sufficient? Or there are women who have breakthrough cancers after a negative screen? Or is it also that even if we pick them early, they have stage progression before they have even gotten treatment? So the whole purpose, while it is nice to write publications, the whole purpose is actually to inform the department. That is why we work with the department, so that even before we have gotten a chance to publish, the department will already be able to act upon what we see. And this is the same principle that we try to use with the other countries. And Rob, you did ask about how to first the trends in the different cancers. So we do have seen different trends, but today we didn't have enough time to show the trends. There are trends that are in HIV-associated cancers that have gone down because of ART. There are trends that there's a big jump after 2011, which is an artifact of reporting, particularly for cancers that are more common in the private sector, breasts and prostate. And geography, at present we are not able to use geography because we don't have patient where the patient stays. We only have where they are treated, which can be an artifact of availability of cancer services in specific provinces like Gauteng, KwaZulu-Natal, and Western Cape. In terms of quality data programs improving access to screening and diagnostics and mortality. So at present, we don't have access to the death registry, but we've signed an MOU so that the death registry can be able to legally share their data with us, and that's sort of still the pipeline. Basically, we're trying to use all this data harmonization to look if particularly for surgical treatment because of the NHLS data, if people who were screened and were supposed to have surgical treatment actually did get the surgical treatment. And then the comment on underreporting, I think this is something that we are well aware of, and I did mention that the pathology-based registry systematically excludes cancers that are not diagnosed by pathological means. And that is why we're establishing population-based cancer registries, which are the gold standard, where we have active surveillance and nurses actually collecting data who are surveillance officers. However, these can only be sentinel because there's no way we can have nurses going into a population of 60 million and collecting cancer data. We just can't afford that. But we have sentinel sites that are well selected to be collectively representative of South Africa's diversity in terms of our population groups, in terms of our socioeconomic. So for example, we have Ekurhuleni, which is urban, and which also has the proportions in terms of our population group of our country. And we have KwaZulu-Natal, which oversamples a minority population, which is the Indian Asian population. And we have the other planned ones are Western Cape, which oversamples the white and colored population, which are minority population groups in our country. And then we have Limpopo, which is a national health insurance site, which looks at if we subsidize funding for cancer care, does this help us improve cancer surveillance? So these sentinel sites are the only sites where we will have active surveillance, and then we use that to correct national estimates. And the reports that you see on WHO for 2022 are actually South African data, corrected, pathology data, corrected for underassessment using the Ekurhuleni population data. So for the first time, we actually have South Africa data on WHO. Before, we couldn't meet the data quality standard.
Concerning the underreporting as well, remember during our presentation we were talking about the notifiable medical condition app that we are now having an NCR model within that app. So once that will be deployed as well, we will be able to get those cancers that have been diagnosed clinically by the doctors in the hospitals. So it might also cover a huge part of the population. So the only thing we might be getting from the population-based registry will also be the one from the death certificate, which will also complement the information that we have. And concerning the database, every day we try to find new methods to improve our linkage, because our data set increases every day, and the tools become limited as well. SQL is actually something we are looking into during the linkage directly into databases, because we store our data sets into an SQL databases. So that is actually something we are looking into. And concerning the access to database, okay.
So in terms of access, so the Cancer Registry database is NHLS data. So it is under the governance of NHLS. So like all the other NHLS data, you have to go through the registration of the NHLS arms, and you need a protocol, and you need ethics. And as soon as you have that, we will be able to support you, from the Cancer Registry to follow up through arms so that you get the data. We've been able to have a lot of other people who are not part of the NHLS or the NCR use the data. Yes.
Okay, have we exhausted all the questions? Okay, as you check the last one, in terms of the underreporting, I think the question was around somebody sitting in the community and they haven't even been diagnosed. So, okay.
So those are, okay, so there's underdiagnosis and there's underreporting. So underreporting is you've been diagnosed, but it doesn't get to us. So underdiagnosis, when we compare the private and public data, we see that in terms of our pathology data, 40% of our reports come from private sector, which means that about 16% of the population is contributing 40% of the reports. So that speaks volumes about the 60% that we're getting from about 85% of the population. So it speaks to the government system causing underdiagnosis because people don't have ready access to diagnosis, whether it is theater lists that have been cancelled or whether it is long waiting lists or whether it is referral to higher levels of care, but we are losing people in government sector. Definitely we are underreporting when we just compare with the diagnosis that is happening in private.
Okay, all right, thank you for clarifying that. And if the question was directed at maybe awareness in terms of people in the community being aware that they need to seek help, that is another level, and there's need for integration of services in the facilities, because sometimes patients can present with something else, but they also have another thing that's bothering them, but it's up to the integration in the facilities so that the diagnosis that we're speaking about can actually be expedited.
The underreporting that we are experiencing, that we are all aware of, especially with NHLS data, and also the underreporting that we are also experiencing when it comes to the doctors not reporting all the cases. We see it also in the NMCs. Is there anything that, or any initiative? I know that getting data capturers do require money, although it's something that we cannot avoid, but then is there any initiative or any effort into that space in terms of correcting that issue of underreporting?
Thanks very much for the talks and unraveling all your hard work. It's a lot of work, very valuable work. I'm very interested in your linking of the people living with HIV and cancer diagnosis. And maybe it's too early to ask this, but from the point of IDORI, we're interested in the connection or links between viral infection and cancer, but of course this is HIV. So have you seen any trends with patients living with HIV and people living with HIV and non-AIDS defining cancers? And sorry, I should say I'm from internal medicine. I'm Clem Penny from internal medicine and IDORI.
Okay, thank you, Clem. I'm going to start with Clem and I'll come to you, Freddie. So we have seen there's so much to be discussed. So we asked Rob if he could give us another seminar only on HIV and cancer based on the South African HIV cancer mix study in 2025. So we kind of like waiting for that slot, but in brief, cancers that have been of interest outside of the obvious, which is Kaposi sarcoma, non-Hodgkin's lymphoma, and cervical cancer. Those are the AIDS-defining cancers, and everybody knows they're HIV associated. But what we have seen in the other cancers that are not commonly known to be associated with HIV, one of the ones that shows the strongest trends, and this work that Carol did, is conjunctival cancer. So it essentially mimics the pattern of Kaposi sarcoma, that it shoots up. It was a no-name cancer that we didn't really know, and then it tumbles down with antiretroviral treatment. We used to see it in elderly white men who do outdoor work in terms of sun exposure, but now it was happening in black men and women who are young, who are in their 30s, 40s, and 50s. We've also seen squamous cell carcinoma of the skin, And there's also some association with melanoma in black people, because melanoma, we had previously seen it only in fair-skinned people, our white and colored population mostly. In terms of the lymphomas, the Burkitt's lymphoma, although they're under NHL, Burkitt's lymphoma is also showing exactly the same pattern that Kaposi and conjunctival cancer is showing, just to give you a small bit. Freddie, in terms of underreporting, from the NHLS, we have access to the whole database. So if it is in the NHLS, we have it. But for those that do not have pathology confirmation, that's how we use the Sentinel sites. And then we use that to correct the estimates. So the Sentinel sites are active surveillance. So we do have nurses who are actually capturing, and the nurses, they go to the clinics, they go to the hospital, mortuary, radiology, they go to every section, pharmacy, looking at chemo drugs prescribed. So they hunt down the cancer patients, and then they feed it back to the Cancer Registry. It's a representative sample that we use to correct national estimates. Yeah.
All right. Thank you. We're running out of time. Is yours a very short question?
Thanks, sir. It probably is. Hi, I'm Mama Puri Kubjani, based at the Health Economics and Epidemiology Research Office. My question was, so as you're exploring these trends at a population level and the determinants, do you then, are you at a stage where you can say, recommend to the Department of Health on preventative measures and cost, and do budget impact analyses and stuff like that?
Yes, we can be able to do that. I think we have actually an implementation science proposal for HIV and cancer, in terms of, based on all the work that's been done on HIV and cancer, what is the so what for it, in terms of awareness, in terms of with HIV clinicians, with patients, with policymakers. But we don't have money for that yet. But we hope we can be able to do that.
All right, thank you so much. Please, let's... Thank you everyone for coming, and I know there's further questions, but from here we have some refreshments outside. You can engage further with the speakers and get all your clarifications clarified. Thank you.